My name is Denise Knox. I'm from Chicago. I've been living with metastatic breast cancer since a year ago this week. Welcome to the Hormone Positive breakout session. Before I introduce our speaker, please remember to use the index cards in your folder to write down any questions. There will be a Q&A session immediately following this talk. Now, I'd like to introduce Dr. Catherine Reeder-Hayes. Dr. Catherine Reeder-Hayes is a clinical assistant professor in the University of North Carolina Division of Hematology Oncology, specializing in breast cancer. She's a health services researcher with expertise in breast cancer treatment disparities and the comparative effectiveness of treatments for vulnerable women with breast cancer. She holds a medical degree from the University of Alabama, a master's degree in business administration from Auburn University, and a Master of Science in Clinical Research degree from University of North Carolina School of Public Health. She is currently the leader of a multidisciplinary research team examining adherence to tamoxifen and aromatase inhibitors among women with early-stage breast cancer using large registry and pharmacy claims databases. She also works on projects using patient-reported information to understand reasons for hormonal therapy non-adherence and to design and test interventions that help patients stay on their hormonal therapies. Please join me in welcoming Dr. Reeder-Hayes.
Good morning and welcome to all of you. I seem to have drawn the big room for the breakout session, so I'm not sure if that's a good thing or a bad thing, but thank you all for coming. So the topic that I was asked to speak about this morning is what I've labeled here hormone sensitive or hormone receptor positive breast cancer. Both sort of the basics of how this is usually treated with hormonal therapies, and then some new approaches that may be treatment options now or in the near future. So first of all, what do we mean when we say hormone sensitive breast cancer? This goes by several names. It may also be called hormone receptor positive breast cancer, ER positive, or estrogen receptor positive, or other names that patients or their doctors may use for this. Essentially what it means is that the cancer cells have a high level of estrogen receptors in the cell, and they are dependent on the stimulation from that estrogen to successfully grow and reproduce and make new cancer cells. For that reason, blocking this estrogen stimulation in one of a variety of ways may be a good way to stop the cancer cells from growing or even cause some or all of the cancer cells to die. So this is a little bit of a complicated graphic, but just to give you an idea of how this happens visually, the red little chemical looking symbols here are estrogen, and little green eggs are estrogen receptors. So estrogen receptors usually live in the cytoplasm, or sort of the juicy part around the outside of the cell. Estrogen crosses the cell membrane and binds to these estrogen receptors, and it basically wakes them up and makes them start doing things. And so the estrogen receptors then go further into what we call the nucleus of the cell, which is the factory in the middle of the cell that contains all the stuff the cell needs to reproduce itself. And they set off a whole cascade of events inside the nucleus of the cell that tells the cell to grow and make more of itself. So since estrogen is so important to this kind of breast cancer, it's sort of important to know where does the estrogen in our bodies come from. And as this slide illustrates, it's a little bit complicated. The hormonal stimulation of breast tissue, both normal breast tissue and cancer cells within the breast, is pretty complicated. But the two things that are most important on this slide are illustrated with the big yellow arrows. So in a premenopausal woman, that is a woman who is still having monthly menstrual cycles, and or a woman whose ovaries are still awake and producing estrogen, the vast majority of estrogen in the body comes from the ovary. And so in premenopausal women, the ovary is usually the focus of a lot of our hormonal treatments. In postmenopausal women, you may already know that the ovaries have basically shut down. That estrogen factory, that reproductive mechanism that's putting out an egg every month and varying the estrogen and progesterone levels in the body to support that egg, has shut down, and you're not having monthly menstrual cycles anymore. But there's still estrogen in the body of a postmenopausal woman. And that estrogen comes principally from the conversion of other hormones to estrogen, and those other hormones are called androgens. They're mostly produced in the adrenal glands, which are these little kidney-shaped glands that sit on top of your actual kidney, and in the fat tissues of the body. And then they're converted by enzymes, principally an enzyme called aromatase, into estrogens, and that's how postmenopausal women get the estrogen that's in their bodies. So there are a number of different ways that estrogen can be targeted in the body of a woman who has breast cancer, either at an early stage in the breast only, or at a more advanced stage when it's spread to other parts of the body. And I'm sure many of you are familiar with some or all of these drugs, but hopefully we can help you understand a little bit better how they may be working or what some of the other options may be other than the drug that you may be on at this time. So the oldest form of anti-estrogen therapy for breast cancer is ovarian ablation, which basically means wiping out the ovary's ability to produce estrogen in a woman who was previously premenopausal. This approach has actually been used since the 1940s, and obviously the oldest technique for stopping those ovaries from working was to actually go in and take them out very early on by open abdominal surgeries, and more recently, thankfully, by less complicated laparoscopic surgeries, but to actually remove the ovaries from the body. But ovarian ablation can be accomplished in some other ways. There are now drugs or chemicals that can be injected to suppress the other hormones in the body that stimulate the ovaries and that essentially put them to sleep. So that's a medical way of doing it. The ovaries can also be radiated. That's fairly complicated and morbid and rarely done anymore unless there's a reason why we can't use these other approaches. So when tamoxifen first came along, which we'll talk about in a minute, there were some studies to look at whether just taking a woman's ovaries out was as effective as having her on tamoxifen. And in fact, tamoxifen plus suppression of the ovaries worked better than just suppressing or removing the ovaries alone. That doesn't mean that it works better than tamoxifen alone, but we can talk about that later. The next class of drugs to come along for the purpose of suppressing or blocking estrogen in a breast cancer was the selective estrogen receptor modulators, or SERMs. Tamoxifen is the flagship drug in this category and the one that you are probably all familiar with to some degree. There are other drugs in the category, including raloxifene and tamoxifen, that are used more commonly either in the setting of breast cancer prevention or in Europe, although Ferristin or tamoxifen is approved for breast cancer treatment in the United States, and on occasion we do have women on that drug. Essentially, the way that these drugs work is that they look enough like an estrogen to an estrogen receptor to compete with the real estrogen to bind that receptor. So basically the estrogen is there trying to hook up with the receptor, but the estrogen receptor modulator is also there saying, hey, over here, bind to me instead. And so there's a competition going on. Once the drug binds to the receptor, however, it doesn't stimulate and wake up the receptor in the same way that real estrogen does. Instead, it works to basically shut that receptor down and keep it from setting off that cascade of growth signals that we were looking at a moment ago. So it basically works to turn off or fool the receptor. So these drugs work both in premenopausal women and in postmenopausal women because they're actually working at the level of the breast cancer cell at the place where estrogen, no matter where it comes from, is binding to the receptor. So they can work before or after menopause and are used in both those settings. A newer class of drugs that many of you may also be familiar with are called aromatase inhibitors. So there are 3 of these, and unfortunately each of them has a brand name and a generic name. So they can be a little bit hard to to keep straight. The generic names are anastrozole, letrozole, and exemestane. The brand names are Arimidex, Femara, and Aromacin. And all of these drugs have recently gone off patent, so there are generic versions of them available, although because it's been very recent, the price difference between the generic and the branded is not always what we would like it to be. So basically, these drugs work by suppressing that conversion in a postmenopausal woman's body of the androgens produced by the adrenal glands and the fat tissue into the estrogens that actually stimulate the breast cancer cell. So they stop that process from happening, and as a result, they lower the estradiol levels in the bloodstream. So these are effective, as you can imagine, only in the postmenopausal woman or in a woman who's been made postmenopausal by having her ovaries removed or having her ovaries suppressed with chemicals. So the way that I explain it to patients is if you're a premenopausal woman, taking one of these drugs is sort of like shutting off your kitchen faucet but having your roaring garden hose going at the same time. So if the ovary is still producing estrogen, these drugs are not going to lower the estrogen level enough to make a difference. Another drug that some folks may be familiar with is called fulvestrant or Faslodex. This is an injected drug. It's a muscular injection, so similar to a vaccine or a tetanus shot, and it's given once a month. It is a direct anti-estrogen. So in terms of the way it works, you should think of it more like tamoxifen, less like an aromatase inhibitor. It actually gets in there between the estrogen and the estrogen receptor to compete for binding sites. So it works in a very similar way to tamoxifen in terms of turning down the receptor signaling, but it also has the effect of actually speeding up the breakdown of the estrogen receptor. So cell parts are recyclable, right? They kind of have to be replaced every few days, weeks, however much over the life of the cell. And basically this speeds up the breakdown of the estrogen receptors so there aren't as many of them that are functional. So that's the other way it works. Again, this drug works best in postmenopausal women, even though it is working at the level of the cell. And in fact, it's only FDA approved for postmenopausal women, partly because that is the setting in which it was tested. But we also use it in women whose bodies have been made or put into a postmenopausal state by suppressing or removing the ovaries. It can also be used in combination with an aromatase inhibitor so that you're kind of getting two different kinds of anti-estrogen targeting, and we'll talk about that some more. So estradiol can also be used in the hormonal therapy of breast cancer, which at first glance seems extremely weird, right? Why in the world would you want to give a breast cancer that feeds off of estrogen? Because estradiol is just a fancy name for the most active form of estrogen in the body. But this is a treatment that has been used actually for quite a long time after anti-estrogen treatments stop working. The idea here is that the estradiol treatments take advantage of the fact that the cell is now hypersensitive to estrogen. So you've taken a cell that loves estrogen, that needs it to grow, and you've starved it of estrogen. So what does it do? It makes more and more estrogen receptors so that it can take advantage of any estrogen it comes in contact with. And you then essentially try to poison it by hitting all those estrogen receptors at once and just basically making the cell's growth mechanisms explode, so to speak. There is really fairly limited evidence in large-scale trials for the use of this therapy, but it does appear that what we think of as low-dose estradiol, which is 6 milligrams per day, seems to be as effective as 30 milligrams per day with fewer side effects. The 30 milligram dose is a very high, super physiologic dose of estradiol and was associated with lots of yucky effects, sort of like if you can think back to when we used to use the extremely high dose oral contraceptive or birth control pills, clotting, nausea, those kind of things, bleeding, those kind of things. So when we use this treatment these days, we tend to use it at the 6 milligram per day dose. When we use estradiol as a therapy these days, we tend to use it at the 6 milligram rather than the 30 what we think of as the older 30 milligram dose. One other therapy you may have heard about is Megase. This is a progesterone derivative, and frankly, although it has been used in metastatic hormone receptor positive breast cancer for a long time, the mechanism of how it really works against the cancer is unclear. It may mess with the adrenal gland's ability to produce the hormones that are turned into estrogen in postmenopausal women. It may act on the tumor itself, on the progesterone receptors in a way that's not good for the cancer cell, or it may do both. We really don't use this very frequently these days. It has a lot of side effects as well related to its steroid character, and there are so many other choices now for hormone receptor positive breast cancer that you really don't see this used very often. So how do the hormonal treatments work? I've touched on this already a little bit, but this is just sort of a visual representation. And this is a slide from a British group of investigators, so estrogens is spelled with an O. So you can see that tamoxifen and fulvestrant down at the bottom are both targeting the part of the stimulation pathway where the estrogen hits the estrogen receptor. And fulvestrant is also hitting the estrogen receptor itself, damaging and degrading those receptors. On the other hand, aromatase inhibitors really don't act on that estrogen receptor relationship at all. Aromatase inhibitors go back a step to where androgens are being converted to estrogens, and they stop that process from happening. So essentially, they decrease the supply of estrogen. So, okay, we have lots of choices. So how do we decide which hormone therapy is right for an individual patient? So there are a number of factors that may affect which one of these treatments your provider may recommend for you at different points in your breast cancer journey. So one thing we look at is the type and the timing of the treatments you've had before. So if your breast cancer came back while you were taking tamoxifen, tamoxifen is probably not going to be the drug that's recommended for you first in the setting of metastatic disease. So sort of the common sense sorts of things that you would think. We look at what you've been exposed to before, how well did it work, and also the length of time since your original cancer. So a woman who was on tamoxifen for 5 years and then her cancer stayed away for 5 more years, tamoxifen may be a good thing for her to go back on, particularly if she's still premenopausal, because it may not be that her cancer grew back despite that tamoxifen. Her cancer may have grown back after she came off the tamoxifen. Of course, we look at menopausal status. We just talked about why that's really important. It's important to think about where the main source of estrogen in your body is in order to know what your options are to combat that. And we also look at the setting in which there's the most research with the drug. So for instance, when I talk about fulvestrant or I talk about high-dose estrogens, those treatments have really been studied the most in women who have already had tamoxifen, who may have already had an aromatase inhibitor. So if that's the setting where there's the most evidence that the drug works well, those drugs may be used further down the line than some of the other choices. And then we also think about our level of concern about what's called endocrine resistance. So that means the cell's ability to change itself such that these estrogen blocking or hormonal therapies don't work as well anymore. And one of the ways that we figure that out is thinking about the length of time that the cancer responded or behaved itself in response to the last treatment. So this is absolutely not gospel. It should go in this order every time, but these are some typical sequences of hormonal therapy for pre- and postmenopausal women. So in most premenopausal women, if you have not had tamoxifen before, tamoxifen will be the first or one of the early drugs that is tried. After that, for the other therapies to work, we really need to do ovarian suppression or ovarian ablation. That can be accomplished, as we said, with either injections or with removal of the ovaries. That therapy alone can often be effective for a while, or it may be paired immediately with an aromatase inhibitor, because once the ovaries are shut down, the aromatase inhibitor is an option. Fulvestrant can also be tried, again, as I said, after the body's been made postmenopausal artificially, fulvestrant can be an option. And then we move on to chemotherapy or other alternatives when this sequence seems to stop working for us. In a postmenopausal woman, usually the aromatase inhibitor will be the first choice. If there is no particular reason not to take that drug, then usually we move on to tamoxifen in the second line, or we may try one of the other aromatase inhibitor drugs, or we may try fulvestrant or the combination of an aromatase inhibitor and fulvestrant. And then at that point, if we've sort of been through that list and things aren't working anymore, now you can go back to that list several times. But if those strategies don't seem to be working anymore, then we usually look at moving on to chemotherapy or other treatment choices, which we'll talk about. So why do hormonal therapies stop working? Why can't we just take tamoxifen or an aromatase forever and hope that it will keep working? And then what do we do? So the reason hormonal therapies stop working is this term that I just threw out, endocrine resistance. So what does that mean? There are different ways that a breast cancer cell can become resistant to our trick of blocking estrogen. So the first type of resistance, doctors refer to as de novo resistance. So essentially what that means is that your cancer never really was responsive to hormonal therapies. So ER and PR, or estrogen progesterone receptor status, is a pretty good way to determine whether a cancer cell is going to be sensitive to these estrogen blocking tricks, but it's not a perfect way. So not every woman who has a hormone receptor positive breast cancer has the same level of sensitivity to estrogen blockade starting out, okay? So you start out from different points, and some women start out with cancers that, although they may carry that estrogen receptor, are not very sensitive to estrogen blocking treatments. You can also have acquired resistance. So that means that the cancer started out being sensitive to blockade of estrogen, but over time it gets smarter and it develops growth pathways that don't depend on estrogen. And then it's able to reproduce itself quite quickly, even though the estrogen stimulation pathway is being blocked. A third thing I wanted to mention is adherence. This often certainly happens with women with early breast cancers who are on estrogen blocking drugs to help keep their cancer from coming back. It's sometimes hard to take those drugs on a regular basis, and the drugs may not work as well, whether you're in the early stage situation or whether you're in the situation of metastatic disease, if they're not taken every day. So that may be a reason that they don't seem to be working well. So how do you know when your cancer has become endocrine resistant? So some of the things we look for are a short interval between the first time you had a diagnosis of cancer and your cancer recurrence. Usually we think of less than 2 years as a sign that we should be really concerned about that de novo resistance, okay? The cancer really just was never very sensitive to estrogen blockade. Recurrence of the cancer anytime while you're on hormonal therapy for prevention. So while you're on that tamoxifen or aromatase inhibitor to protect you from your cancer coming back after the first diagnosis. If you recur within that period, that could still be de novo resistance, or it could be a sign of acquired resistance. And then lastly, and probably most importantly, not getting a response to estrogen blocking therapy when you've had one before, or having a short duration of response when before perhaps you've been able to be on an estrogen blocking drug for 6 months, a year or more, may be a sign that the cancer is developing resistance to estrogen blocking strategies. So this has been an area of very active interest and investigation among scientists, is what can we do about this phenomenon of estrogen resistance? So there are basically 2 choices, right? When we think the cell has become resistant to estrogen blocking approaches, we can either move on to chemotherapy, which doesn't depend on blocking estrogen, or we can in some way try to reverse that resistance. And really, until quite recently, it was usually the first strategy, switch to chemotherapy. This was what triggered switching to chemotherapy. There's been a lot of interest among breast cancer researchers in ways that we can perhaps set the clock back, resensitize the cancer to estrogen, or get around the sneaky ways it has developed to grow despite estrogen blockade without moving on to chemotherapy, or to traditional IV chemotherapy, certainly. So another complicated slide that we don't have to go through. But the thing I want to emphasize is, okay, here the big green jelly bean over here is the estrogen receptor. So, and the arrows that go to and from it are showing how pathways that involve the estrogen receptor stimulate that cell growth. But you see all these other jelly beans over here? These other jelly beans represent other signaling pathways within the cell, other ways that the cell gets growth signals that are not dependent on estrogen. So when the estrogen pathway is blocked by estrogen blocking drugs, there are strategies that we've just talked about, the cell becomes more dependent on these other pathways to grow, okay? And it may do what we call upregulating those other pathways, which means making more of those receptors, making more of those enzymes over here on the right-hand side so that it can use those other pathways and keep growing and keep reproducing. So the reason that's important is that it's something we call combination therapies. Okay, it's not quite as much fun as the McDonald's combination, but it's probably better for you. So the idea here is, okay, what if we hit that estrogen receptor growth pathway, but at the same time, we go over and hit one or more of those other pathways that the cell is depending on when the estrogen pathway is blocked? Would that work better than estrogen blocking therapies alone? And would it work better in women whose cancer seemed to have become resistant to estrogen blockade? So there are a few new strategies that have been tested and are actually available, and there are some others that are being tested now and hopefully may turn out to work well and be available to all breast cancer patients in the near future. So one of the first things to be tried was what we call dual estrogen targeting. So the idea here is, do two of the estrogen blocking drugs work better than just one, right? So the first trials that looked at this were really with aromatase inhibitors and fulvestrant as a combination. As a combination that's pretty tolerable to folks. So there have been a number of trials looking at this question. The SOPHIA trial asked whether women whose cancer has progressed on anastrozole, so you've been using that aromatase inhibitor, anastrozole, and the cancer seems to have gotten past that and started growing again. Did they do best by switching to another aromatase inhibitor, getting a whole different kind of anti-estrogen treatment in a fulvestrant injection, or doing both at the same time? So that was the question of this study. And yeah, sure, great, okay. So the skinny on this trial result was that it was negative. Women who were on the combination treatment seemed to do about the same as women who were on one of the single treatments. Now remember, this is in women whose cancer has grown on first-line therapy. In contrast, there have been two other trials that basically looked at doing this for women who have not been treated for their metastatic breast cancer before. And the bad news is they had opposite results. So the FACT trial did not find a difference for the combination of fulvestrant and AIs, whereas a trial conducted by the SWOG cooperative group did find a difference. These differences may be due to different kinds of women who were enrolled on the trials. They were all what we call first-line metastatic patients. They hadn't been treated for their metastatic disease before, but significantly more women in the SWOG trial were women who had metastatic breast cancer the first time they had a breast cancer diagnosis. So they hadn't been exposed to chemotherapy or hormonal therapies before when they had their first breast cancer diagnosis. And they may be more sensitive for some reason to the combination. So The short answer is the combination may be right for women in some circumstances, but it may not also be right for every woman. So new strategies, and I'm going to run through these quickly so I can get to your question. So the one that's available right now really to all breast cancer patients is hitting a target called mTOR with a drug called everolimus, which is an oral targeted chemotherapy that's used regularly in some other cancers. 2 studies have looked at this in women whose cancer grew on an aromatase inhibitor, and adding everolimus and going on with an aromatase inhibitor seems in some women to reverse that resistance and keep their cancer from growing without having to go to traditional chemotherapies. EGFR and HER2 inhibition. So some women have the situation that their cancer is not only positive for hormone receptors, but also positive for the HER2 receptor. In those women, we have trials that show that combining an aromatase inhibitor with a HER2 targeted drug works better in terms of the time before the cancer starts growing again than an aromatase inhibitor alone, but we don't know that this would be a good strategy for women whose cancers don't overexpress HER2. These are just a list of other targets, so usually there's a letter number combination that represents the target within the cell. And these are some other targets that are being looked at for targeted drugs in combination with endocrine therapies, but they haven't been proven yet. They're not out there on the market for everyone yet. So what's the harm then in doing 2 treatments instead of 1? You know, I get this from my patients a lot. Hey, I'm willing to do whatever. Let's do 2 drugs instead of 1. Won't it work better? It may. So the advantages obviously are that in some combinations you may have a higher chance that your cancer will respond to this strategy. It may give you a longer time before you have to change treatments. It may extend survival or extend your lifespan. That's the hardest one to prove, frankly. And if you do this in the context of a research study, then one advantage is that you may be able to help other women with the information that you contribute to the study. There are some disadvantages to combination therapy. There's a higher chance of side effects. Certainly the addition of everolimus, although it's not like going into the infusion room for IV chemotherapy every week, it's not free of side effects. It may cost more to be on a combination therapy depending on how you are paying for your drugs. You almost certainly will have to take more pills or perhaps get an injection as well as a pill. And if you're doing this in the combination of in the context of a research study, you may also have to travel, go further, come in for more tests or more frequent visits in order to be in that research study. So these are some combination therapies that are currently available in the context of research studies at UNC, or that will be available over the next few months. So I won't run through these in detail, but the overall point is we are testing CDK4/6 inhibitors in several different trials and heat shock protein inhibitors in one trial in women with metastatic disease at different points in their breast cancer treatment course. So certainly some folks may be eligible to join one of these research studies if that's of interest to you. And these are some resources where you can find out about clinical trials. If you're interested in what trials may be available across the whole country, clinicaltrials.gov is a good resource. There's also the Lineberger Comprehensive Cancer Center, which is the UNC Cancer Center website that is specifically about clinical trials. And Lineberger also has a number that you can call to find out which studies may be available that are right for you. And I think there's some sessions later on today or tomorrow that deal with that specifically in more detail. So if it's okay, we're going to move on to questions. And I think I'm happy to answer questions in whatever format, but I've been told that I should focus on the cards. Okay.
I hope you heard the questions are.
Okay. Okay, should we just start? Is there an order here of which ones were submitted first?
These, if you want to work back to front.
Back to front, okay. Sure, okay. Could you please explain having a low % hormone-driven breast cancer I am only 20% ER positive. My breast cancer is being driven 80% by an unknown. I consider myself closer to triple negative breast cancer. Anti-hormonals are not working. However, I continue to be treated as ER positive. So the percentage of estrogen receptor is confusing to a lot of folks. And it really has more to do with how the test is evaluated in the lab than it does the percent of your cancer that's sensitive. So almost no woman has 100% ER positive tumor. When you stain those cells for estrogen receptor, not every cell is going to take up the stain and look positive on a slide. That doesn't necessarily mean that that cell isn't sensitive to estrogen blockade biologically, or that estrogen receptor blockade won't work. Women who have low percentages of the estrogen receptor by what we call immunohistochemistry, or this kind of test, are a little bit more likely, if you look at their tumor on a genetic level, to have what we call a luminal B, or a little bit less classically estrogen-sensitive tumor. That still doesn't mean that an estrogen blockade wouldn't work. However, if, as this person is saying, they have been through several courses of hormone receptor positive directed treatments, so anti-estrogen therapies, and they aren't working, that may be a sign that this tumor either was resistant from the beginning to estrogen blockade or is developing or has developed resistance to estrogen blockade, at which point it may be time to move on to chemotherapy. I think, I am so sorry, I'm seeing people waving their hands, and I'm being told I should work off the cards, so I'm glad to answer afterwards as well. Do you think stress and the attendant impact on adrenaline and estrogen levels causes cancer? I think the simplest way to answer that is probably, so no, there are no studies that show that stress causes cancer. That's the easy way to answer it. I think the underlying question is, does a woman who has more estrogen in her body have a higher chance of getting a breast cancer or getting a cancer? And I think the easiest way to think of that is to realize that most breast cancers occur in postmenopausal women who have dramatically lower levels of estrogen in their body than premenopausal women do. They still get breast cancer. So it doesn't necessarily mean that if you drew the estradiol levels of two women and one of them was higher than the other, that that woman would be at higher risk of developing breast cancer. All right. Is it safe to use a targeted estrogen such as Vagifem for vaginal dryness when using an AI? It's a good question, and there aren't large-scale studies, and there probably aren't going to be, because nobody wants to take a woman with breast cancer and expose her to an estrogen and randomize her to getting it or not, and then see if her cancer gets worse. It's not a popular sort of trial, either to design or to join. There are some small-scale studies in women who are on these drugs for prevention of recurrence, so women who've been treated for an early-stage breast cancer and are on an aromatase inhibitor. The level of absorption into the bloodstream from a vaginal estrogen is probably low, but there aren't any studies that are big enough to really adequately answer the question, does it increase my risk at all? And I would say in a woman with metastatic disease, you're kind of dealing with a different situation because we already know your risk of having breast cancer in your body at the time you're on this aromatase inhibitor is 100%, right? As opposed to the woman who's taking it for prevention, who's very unlikely to have her cancer come back anyway. And for that reason, the risk of maybe a little bit of absorption into your bloodstream is a little bit different for you than it would be for a woman who's taking it to prevent recurrence. There have been some studies with vaginal testosterone and other sorts of hormones trying to deal with the vaginal dryness from aromatase inhibitors, which can be severe. And I also have conversations with women about this may not be the ideal thing to do, but if the choice is between giving you a vaginal estrogen and taking you off the drug and is working for you, then maybe we should try the vaginal estrogen before we take you off the drug. if it's a choice between not being able to use this drug anymore and using a topical estrogen for treatment of severe dryness. But there are gynecologists who are very good at this and who specialize in this, so asking for referral to someone who could go through all the options with you, including both estrogens and other ways to treat it, is definitely a good idea. Fat tissue creates the androgens. Are there any studies that show a benefit from reducing the amount of fat? No. So fat tissue does produce androgens. The adrenal glands in the body also produce androgens. So we don't have any direct evidence that just walking around with more fat tissue worsens the prognosis of your hormone receptor positive breast cancer, at least in the metastatic setting. Why? It's not great for you, but well, that's another day. Yeah, that's right. Why do you think hormone receptor positive breast cancer is the most common of the currently known subtypes? Hormone receptor positive breast cancer is by far the most common type of breast cancer, both in women who get it at an early stage and in women who have their cancer come back. I don't know that there's necessarily a why to that, but breast cells, even healthy breast tissue, are just made to be stimulated by estrogen. And so it sort of makes sense that if a healthy normal breast cell is stimulated by estrogen, most of the cancers that arise in that tissue are also going to be sensitive to estrogen. So it's a function of the kind of tissue that the cancer develops in. If that makes sense. What is the first indication that a drug is no longer working? How do we know it's time to move to the next drug? So usually the way that we determine that a drug is no longer working is based on interval scanning, either with CT scans, bone scans, or PET scans, depending on your situation and exactly where your cancer is. In some women with metastatic breast cancer, the only place you have the cancer is in your bones. That's actually quite common. In some women, those bony lesions can be a little bit tough to follow on imaging studies. And so some women and their providers use tumor markers, or also called breast cancer associated antigen, or CA2729. There are a few others out there as well. And they track the levels of those in combination with their scans, so that if you have bone-only disease, that may give you an earlier or more reliable indication from the combination that the cancer is progressing. And there are also often times when it's a close call. And in those situations, we may suggest that you have your next scan a little sooner than we had planned. So if there's something that we're not yet sure is bigger or is growing or is a new spot, then we can look at that again pretty quickly and see if it's time to move to a different therapy. It very much depends on the woman and where her cancer is located. Symptoms can be a good indicator, but many women have progression of their cancer without new symptoms as well. Mm-hmm. Okay, one more. If you experience progression on one particular AI, does that infer that the other AIs would not be effective as well? It does not. You will have a lower chance of response to your second-line AI than you did to your first, but that doesn't mean it won't work, okay? So if you took 100 women and you gave them an aromatase inhibitor and they had never had it before, most of them are going to respond. If you take a woman whose cancer has grown on one aromatase inhibitor and you give her a different one, and you do that to 100 women, the percentage of women in that group who are going to respond the second time is lower, but it's not zero by any means. So switching from one aromatase inhibitor to another can be a good strategy, particularly if it's been an easy drug for you to take, and particularly if you're going to get another scan in 3 months, and if things are continuing to grow, then you still have the choice to go on to another drug. Okay, thanks. So, and I can stay for a short time afterwards as well if people want.